Imagine the chaos of a Civil War battlefield. The roar of cannon fire, the crack of rifles, and then the sudden, searing pain. What happened next for a wounded soldier was often a matter of seconds, and the medical practices of the time were far different from what we know today. In the American Civil War, medical practices for battlefield wounds primarily revolved around immediate, albeit rudimentary, care on the field, followed by extensive use of amputation for severe limb injuries, and basic attempts at hygiene in field hospitals, all under conditions that we would now consider appallingly insanitary. The driving forces behind these practices were largely shaped by two critical factors: the devastating power of the mini-ball and a profound lack of understanding of germ theory. The mini-ball, a conoidal soft lead projectile, flattened and tumbled upon impact, creating massive, jagged wounds that shattered bones and tore through tissue. This often made limb preservation impossible, as infection was almost a certainty. Without knowledge of microscopic pathogens, surgeons operated with unwashed hands, dirty instruments, and often in crowded, insanitary field hospitals. The primary goal was to remove the damaged limb quickly to prevent the inevitable spread of gangrene or sepsis, which were rampant and often fatal. Furthermore, the sheer scale of casualties overwhelmed medical resources, forcing rapid, decisive, and often crude interventions. When a soldier was wounded, initial care might involve a basic field dressing, if one was available, and then transport to a field hospital or aid station, often located near the battle lines. Here, doctors would perform a rapid triage, assessing the severity of the wound and the soldier's chances of survival. For shattered limbs, immediate amputation was the most common and often the only recourse. Surgeons worked quickly, often without full anesthesia, using bone saws and scalpels that were rarely sterilized between patients. After amputation, the stump would be dressed, often with lint or other available material, and the soldier would be moved to a longer-term hospital for recovery, where infection remained a constant threat. While conditions were primitive, the Civil War era also saw crucial advancements. Anesthesia, typically chloroform or ether, was widely used, mitigating immense pain during surgeries, although its application was not always consistent. The United States Sanitary Commission, a civilian organization, played a vital role in improving camp sanitation, hospital conditions, and the distribution of medical supplies, working to supplement the often overwhelmed Army Medical Department. Furthermore, the conflict spurred the development of specialized military hospitals, improved record-keeping, and laid foundational groundwork for future public health initiatives, marking an important, albeit brutal, chapter in military medicine. Understanding these medical practices reveals not only the immense suffering endured by Civil War soldiers but also the ingenuity and dedication of medical personnel working under unimaginable constraints. The lessons learned from the sheer volume of trauma, the pervasive threat of infection, and the critical need for organized medical support directly informed later military medical strategies and contributed significantly, though indirectly, to the eventual acceptance of germ theory and modern surgical antiseptic practices, forever changing how we approach battlefield care.